Well, hello.
Hello. How are you
Is it?
doing, Vince?
I'm good. Is it just us on the call?
Nope, we've got attendees on, and for everybody that's on the call, we'll be starting in we've got 1 minute. We're just waiting for everyone to come in, and then we'll get started. All right, good afternoon, everyone, and thank you for attending episode 3 of our PinPoint Plans webinar series. Just appreciate everyone taking the time this afternoon. Even I think if you're on the West Coast, you just turned into the afternoon. And if you've participated along with us through this webinar series, you get kind of the flow of it. We will have questions open throughout. If we see a presenter and we see some questions coming in, we'll probably take those questions throughout the meeting. So if you look over in your question and answer section, please feel free to enter any questions in as we go. We'd much rather take those questions at the time that you think of them. Otherwise, we, of course, will open it up for questions at the end. This is episode 3 in the series. We'll have a couple more episodes coming in the next few months, and we'll talk about that a little bit at the end and just let you guys know what's coming on the subjects there. So without further ado, we are going to jump in. My name is Sarah Klein. I'm with 44 North. If you've been on the other presentations, you've probably heard from Lester Morales, and so I will try to fill his shoes and be as engaging as possible. As part of the presenters, I'll be jumping in here and there, but the subject and the focus of today's webinar, compared to maybe the other ones we've had, is solely on prescription drugs. And if you look at the numbers here, the cost of prescription drugs is rising at a pace that's surpassing the increase of medical claims. So these numbers are 2017 to 2018. Health benefit costs increasing 3.2%, whereas in general, drug benefit costs are increasing at 6.5%, and then specialty drug costs, the really high cost drugs, increasing at a rate of 11.9%. And what a lot of people think are the carriers and PBMs are working on it. They're going to fix it. We've started hearing that, and we've been hearing that for years, right? There's all these cost containment strategies being put in place to control the cost, and yet we still see that increase growing faster than what medical costs are. So here's some examples of what the big carriers and PBMs, how that works. You've got your insurers, your PBMs. The PBMs have their own specialty pharmacies and provider services. And if you look at that second column, Aetna, you think usually of that insurer, that carrier being the big guy in the room, but we all know that CVS is purchased Aetna. So the PBMs are definitely growing even bigger than what the medical carrier is. Back to specialty drug spending being on the rise. More current numbers, 2020, the expected is $401.7 billion being spent on specialty drugs. And we're going to spend some time, a significant amount of time, on those specialty and high cost drugs. So you want to hear this as an employer. How are we going to control specialty drug costs? And what some of those carriers are doing that are more maybe in the traditional, you're seeing this, is putting in place things like prior authorizations for specialty medications, managing the site of care. Where is it actually being delivered? high touch case management. So again, those high cost drugs, do we have case management in place that is maybe managing the therapy? Maybe there's a coaching program. Specialty medications obtained only through, again, that chart, those PBM specialty pharmacy. So those are some of the things that employers have been focusing on to manage the cost of specialty medications, but that's not all that's out there. And so that's what we're working on, wanting to educate you on today, are some other strategies that you can put in place that are going to be more effective. So introductions, we're going to, in just a moment here, I'm going to show you who our experts are, and you can see their pictures. All of our cameras are on the side there, and then we'll get into Q&A after everyone's presented, and then a call to action after that. The webinar is being recorded, so if someone on your team couldn't attend today and you want to pass this along to them, that recording will be available and that replay will be out tomorrow. So please ask questions again throughout. Feel free to put your questions in. So who are you going to hear from today? Again, my name is Sarah Klein. I'm the Chief Operations Officer for 44 North. We're an employee benefits focused broker and also consultant when it comes to high cost drug management. We also have Susan Hayes, who's a principal of pharmacy investigators and consultants, and she'll tell you a little bit about her in just a moment. And then we also have Pete Cohen, partner development at Clever RX. And finally, Vince Babcock, who's a principal and benefits consultant with me at 44 North and an expert with the AeroRx and high cost drug management. If you hear nothing else today, we want you to take away 3 key points. And we can always follow up afterwards and we'll talk about takeaways at the end. But the 3 things we want to really point out is that the current RX model is broken. Number 2, members are already ahead of carriers and employers in controlling their own costs. Right? Some of the things that we've been doing as employers along the way is increasing those copays and those cost shares. Well, members have gotten smart and they actually know how to use some programs to control their own costs. So they're ahead of the game. The system is 2 steps behind. And number 3 is that plans can save while improving benefits to members. So we've always been told the opposite. In order to save, you actually have to decrease benefits, and that's not the case. You can save, your costs can go down while you actually improve benefits to members. So without further ado, why is the RX system broken, right? Point number 1. And so I'll introduce Susan Hayes to you, and she's going to take us through why it's broken.
Great, thank you, Sarah. I really appreciate the opportunity to speak to you today, and I really appreciate the time. Well, I think Sarah will be moving the slides on. So if you want to go to the first slide, Sarah. Great. So I have the really wonderful task, challenging task of explaining the entire prescription drug industry to you in 15 minutes. And I'm really not going to do that. I'm going to just kind of overview the prescription drug system and let you know that if you're confused by the system, it takes years to really understand the pharmacy benefit system. The folks on this panel have many, many years of experience in the pharmacy benefits arena. So if you are new to this, if you're new to self-insurance, this is going to seem very complicated to you, but there's just a lot of moving pieces. And Sarah was right on when she said the system's broken, but you can fix it without adversely affecting your employees. And that's the message I want to convey to you, that you can fix the system without adversely affecting your employees. There are lots of as I mentioned, entities in the system. When you think about on the far left-hand side here, the drug wholesalers, starting at the top, drug manufacturers making prescription drugs, selling them to the wholesalers on the far left, pharmacies in the bottom corner or bottom middle there, buying the prescription drugs from wholesalers, and then delivering them to patients. And in the back room, if you will, pharmacy benefit managers adjudicating claims and third-party payers like you actually paying for prescription drugs. So when you think of all of this on a $400 billion scale, you start to understand how complicated the system is. And really everyone in this overhead has a slide, has a financial interest in the system. So no matter whether you're the manufacturer, the wholesaler, the pharmacy, everyone is making money, and particularly the PBM, and the third-party payers ending up paying the bill. So that's what we really, want to point out here, that it is a complicated system, and you're only kind of a fraction of over on the far right side paying the bill. Sarah, if you want to move ahead. I'm going to go over some basic terminology that both Vince and Pete will be talking about. AWP is the average wholesale price. It is a published price. It is only published by Metaspan. There are no other national pricing guides other than NADIC. And I'll get into NADIC in just a second, but the average wholesale price is basically the price that most, if not all, except one PBM uses to discount the cost of drugs. So it's very important that you kind of understand what AWP is, because this is where all your discounts come off of, whether it's for brand drugs, specialty drugs, generic drugs, and no matter what the distribution channel is, whether it be retail, mail, or specialty facilities. NADIC pricing is not on here. NADIC is NADAC, and it is the National Average Drug Acquisition Cost. It is published by CMS, and it is kind of a newer way to price prescription drugs. And it is a database published by the government. MAC prices are prices assigned to generic drugs by your PBM, and those prices differ by day, by client, and by line of business. So the PBMs actually use MAC pricing. If they're not meeting your performance guarantees, they can adjust the MAC pricing to meet the guarantee. And conversely, if they are meeting or exceeding the guarantee, they can raise prices on you. And so this is a fluid pricing point that you need to understand as you manage prescription drugs more. Obviously, we've used the term PBM, that's your pharmacy benefit manager. Sarah showed you a slide that showed the PBMs that are owned by the big insurance companies. Obviously, CVS Caremark owns Aetna, so the other way around, but PBMs can also be freestanding, independently owned. For example, MedImpact, Navitus, Maxor, they're all PBMs, as well as the ones that Sarah showed you on the first slide. Brand drugs are drugs that are only manufactured by one manufacturer. So basically, the FDA allows one manufacturer to manufacture a particular chemical entity or drug for a given period of time, usually about 20 years from the time that the molecules are discovered. And then additional manufacturers can manufacture that product under FDA approval as well, and those are called generic drugs. So basically a brand drug is a drug that has no competition, and generic drugs has competition from an identical molecule as the brand drug. There are other competitors within a therapeutic class, and those can be competition from other brand manufacturers, from a specialty manufacturer, and from generics. So it gets a little complicated. Specialty drugs, I want to point out that everybody has their own definition of specialty drug. My particular definition of specialty drug, and I've just recently written a white paper on specialty drugs that is available on my website. But in parts of that will be published in the International Foundation's magazine in December and January. But specialty drugs are really biologics and orphan drugs. If your PBM is telling you that generic drugs are part of the specialty drug mix, you need to take note, because specialty drugs are really considered biologics. And biologics are manufactured differently than small cell or small molecule brand and generic drugs. And biologics are made, hence the name, from biologic or organic materials like blood, plasma, other cells within the body. So they basically cannot be replicated through ways that brain and generic drugs can be replicated by taking some molecules and putting them together. That's really what a small molecule drug is. Specialty drugs are large molecules, and they're made from living organisms, which is why they are different. Orphan drugs also get the status of specialty drugs because orphan drugs are a special designation by the FDA of drugs that cover a small portion of the population, like maybe only a couple 100,000 lives, but are very expensive to manufacture. So the government gives manufacturers of orphan drugs special benefits like tax write-offs and other benefits. And so orphan drugs are really also considered specialty drugs. And if you ever want to discuss any of this, I'll be happy to in detail. Different models, different fee methods. I think this is really important as you venture into prescription drugs. Your PBM will offer you a contract and a proposal, and you really want to take a look at what pricing methodology your PBM is offering you. Traditional PBMs, such as we just talked about, Aetna and CVS, Cigna and Express Scripts, they are carved in, so they're carved into the medical benefit. That's what we mean by carve in. And again, some traditional PBMs are also carve out. You can get Caremark without getting Aetna. You can get Express Scripts without getting Cigna. And MedImpact stands alone. Optum also you can get with and without United Healthcare. But the difference between traditional and pass-through is that traditional PBMs take money on spread. And we're going to talk about that in a second. Pass-through models are just that. They, what they reimburse the pharmacy, they charge the client. Hence, these pass-through models have the kind of negative is that they have a PMPM or per claim fee. The traditional PBMs, because they take their administrative fee as spread on the actual ingredient cost, typically have no fee. So when you look at a deal or you look at a proposal from a PBM, take note if there is an admin fee, an administration fee, because if there is not an administration fee, then that PBM is not providing you services out of the love of their heart. They're providing services to you and taking spread on claims. There's also purchasing groups, and I've listed some of the major coalitions here, but these purchasing groups can help you from the idea that if you are a small employer, they can give you the weight of group purchasing. But some of the problems are they give you the weight of group purchasing. And what I mean by that is that you have little control over the contract between the PBM and the coalition, and you have very little control over the contract that you have between you and the PBM. And there are kickbacks or marketing allowance agreements between a quote consulting firm or like a Mercer or Towers Watson and the coalition. So they're making money on this deal. So if you think they are objectively evaluating whether or not this deal is good for you or not, they are not, because they have marketing allowance agreements that actually puts money in their pocket when they recommend their own coalition to you as a client. And then there's the what I call quasi-consultant PBM models. So these are kind of popping up. RX Benefits is one, Empirics is another. They do allow smaller plans to have access to some of the big three or more vigilance than you would normally get. But it's kind of a false sense that the PBM's interests are aligned with the plan. And again, there's undisclosed spread between that particular entity and the PBM. So they're also getting marketing allowances. So Sarah, if you could please. All right. So I mentioned spread pricing. It's a difficult concept to wrap your head around. And let me kind of just take you through an example. And I always say this kind of jokingly because it starts out, you walk into a pharmacy, kind of like you walk into a bar, and this is what happens. So you walk into a pharmacy with an atorvastatin prescription. So it's a statin medication. It's used for cholesterol, anti-cholesterol. And so You walk into the pharmacy, you present your prescription. The pharmacy is going to receive, for example, $12 back on the pharmacy's MAC list. So that particular PBM has established that $12 is the quote cost for that drug, and the pharmacy gets reimbursed. Let's say if you pay the pharmacy $10 as a member for your copay, the pharmacy is going to get an additional $2 or $12 total. Now, the PBM takes that prescription and re-adjudicates it before they send that to the plan sponsor based on a different MAC list or based on a relationship or a discounting proposal that they have with you as the plan sponsor. And on that list, they charge you $200. This is an actual example, although pretty dramatic, an actual example of how spread pricing works. So basically the PBM has taken $188 as their fee for this prescription drug, this generic drug. So again, reimburse the pharmacy $12, charge you $200, keep $188. So Sarah, if you would, go to the next one. Rebate spread pricing works very similarly in that the drug manufacturer, the pharmaceutical manufacturer, offers to the PBM a whole variety of different kinds of rebates. So this is where the rebate hasn't been, where the rebate is kind of loosely defined. So there can be formulary rebates, so rebates to get the product preferred on a preferred list, or excluded. There's even more rebates if that product, if their competitors are excluded and that product is the only preferred in that therapeutic category. There's market share rebates, so as the market share of that product becomes more than the market share of their competitor products, you can get additional rebates. The PBM can also sell claims data of not only the drug in question, but the drug within the therapeutic category and all the other drugs within that therapeutic category. They can sell that data to the manufacturer and get more money for that. And of course, they can provide clinical and human resources to make sure you stay on the drug or that you take the drug timely and that you continue to use that drug as opposed to manufacturers' competitor products. So those are kind of like in 30 seconds or less, all of the types of rebates that are available. Now, the manufacturer can pass on, the PBM can pass on maybe just the formulary rebate, which is just the rebate to get that drug on the formulary, and keep all the rest. So it's very important when you look at your contract that you know what the definition of a rebate is, because it can be just the formulary rebate, or it should be any and all monies paid by the manufacturer that are passed on to you. As a plan sponsor, you're paying the bill of this very expensive drug, and you need to get all the money back and not have it sit with your PBM. Or if it does sit with the PBM, you know what it is, and that's a fair price for the services they're offering. Okay, Sarah? So again, trying to do this in 15 minutes or less, here's a checklist that you need to kind of walk through, and again, hopefully get some consulting expertise on when you look at your PBM contract. And I don't know if any of you have read this, but if you have trouble sleeping at night, instead of taking Ambien, maybe you want to read your PBM contract. It's usually 30 to 60, and I've seen some contracts that are hundreds of pages for a PBM contract. So this would be a good bedtime reading. But if you do read your contract, you want to kind of go through this checklist. First of all, as I mentioned, is there an administrative fee? Because if there's not an administrative fee, your PBM is probably charging spread pricing, which is undisclosed, and you have no idea what that is, that you're paying your PBM for as a fee for their services. So is there a disclosure that says that the PBM reimburses the pharmacy less than what it charges you? That should be disclosed. You should not only know that there's spread pricing going on, but what that spread is. The state of Ohio's comptroller just did a recent audit about 1.5 years ago, and they found that Caremark and Optum's spread on the state of Ohio employee business was 8 to 10% of the actual cost of prescription drugs. Will the PBM permit contract negotiation? And I want to even broaden that and say, not only will the PBM permit contract negotiation, but will entities like an RX Benefits permit contract negotiation? If you can't negotiate a contract, then it's not really a contract, because contracts are intended from a legal perspective to be a document that both parties can negotiate. And so you need to be able to negotiate certain terms. If you need to pay your PBM, every other Friday instead of the 15th and 30th of the month, you need to have that kind of flexibility. And similarly, if some of these definitions are inappropriate, you need to make sure you can negotiate better definitions. And that gets to the next point. Can you freely audit the PBM contract? Can you hire your own auditors, or are the auditors only designated? The only auditors that you can use are designated by the PBM. Are these the discounts and dispensing fees and rebate guarantee? These are called financial performance guarantees. Are there lots and lots of exceptions? So when you see the financial performance guarantees at the end of your PBM contract, are there 30, 40 different kinds of exceptions? So limited distribution, specialty drugs are excluded, or over-the-counter drugs like aspirin that are required in a pharmacy benefit plan, are they excluded from the financial performance guarantees? What about prescription drugs from long-term care facilities? And so, they even get very fancy. I just saw a contract that if it's a brand or generic drug, but it has a DAW code, a dispenses written code, a certain dispenses written code, that's excluded from the financial guarantees. So you have to really look at the fine print and see what is being excluded. Is the liability limited? If you don't know what your PBM is charging you, but their liability on this contract is limited to just their fees, that's a problem. First of all, you don't know what the liability is then. And then secondly, the liability can be a very small percentage of the overall dollars that you're spending. So again, if they misprice $1 million worth of prescription drugs, but the liability is only $50,000, then you're going to be out a lot of money if there's problems in the contract. Can you understand these contract terms? These are contracts that are made, developed, so that a lot of people really have difficulty understanding this. Even very skilled ERISA attorneys have had problems interpreting some of the terms in PBM contracts. So again, if you don't understand a term, ask about it. It's not a stupid question to ask what they mean by some of these terms in the contract. And they should be able to explain these terms to you. And lastly, what services does the PBM actually perform, and what are subcontracted out? Again, if this is just a shell of a PBM and they have a rebate aggregator, so they're not doing their own rebates, that means that aggregator is taking money. And likewise, if the retail network is subcontracted out, that means there's another entity taking spread on the retail contract. So you really have to deconstruct these contracts of who's really providing you the services and what services are they providing. And Sarah, I'll turn it back over to you at this point, and I'll see if there's any questions. If not, I will allow Pete to go next.
Sure. Thanks, Susan. For all of you on the line, one of the big things take away from that, right? The system is broken when we narrow it way down. But for those of you that are in a fully insured situation, all those things Susan just talked about, the rebates, the spread pricing, you have no idea what's going on behind the scenes when it comes to those big carriers and how they're managing the plan and what is actually coming back to your plan and what's usually not coming back to your plan when it comes to those rebates. So self-funding in general, moving from maybe a fully insured situation to self-funded can seem overwhelming. You do need a trusted partner to help in that, but just know that those partners should be looking at all of those things, looking at the contracts, looking at that spread pricing, doing that negotiating for you. So thank you, Susan, for taking a very complex structure of what the pharmacy benefit space looks like and condensing it down to that 15 minutes for us. And I don't have any questions for you right now in the queue, but certainly we'll look at seeing if there's any at the end there. So thank you.
Thank you.
So Pete, we just talked about all of that structure behind the scenes, and we didn't really talk about what are consumers doing now, because in their mind, right, average consumer, when they think of what is the cost of a medication, usually they're thinking, what's the copay? But as copays have risen, right, and they're looking at how do they control their costs, they've been very smart about what opportunities are out there for doing that. And probably, you know, not that long ago, we thought it might be crazy to be able to look on your phone and see, oh, I can get that cheaper across town. And now there are lots of providers out there. So tell us a little bit about what are consumers doing?
Well, perfect. And thank you for the lead. And that presentation that Susan did is, you know, if anybody's like me, you're very overwhelmed, and that's a lot to think about and take in. And so what I want to talk about is something that's super simple. And this is just a layer that goes on any benefit plan. It's not a replacement for anything else. It's in addition to. And it's allowing your employees to become, as Sarah said, consumers. They're able to make decisions, buying decisions for them and their family when it comes to pharmacy drugs. Technology has allowed for that, and in a lot of cases, there's a lot of medications that people take that if they pay a cash price for, in many instances, it is cheaper than it would be using the insurance plan. And then all the stuff that Susan was talking about with the rebating and the you know, the PBM involvement and all that stuff that goes on that in the back scenes kind of all goes away. And so really it is that the need is there for that kind of consumerism. I think we've all seen that. There are about 250,000 people right now that could benefit from using a benefit like CleverRx, where they're going to have access to technology that will help them make, again, a buying decision on the best way to purchase that prescription for their family. A lot of people, and maybe you've seen this yourself, are moving to high deductible healthcare plans where they are losing a lot of pharmacy coverage until they meet a certain deductible. There's a lot of underinsured people out there for their needs. And then you've got a significant amount of people moving on to much higher copays and so on and so forth. And then, you know, lastly, about 40% of Americans still to this day don't fill a prescription due to high prices. And if you think about that, just on your health plan in general, if somebody's not being a good steward of their medications and they're not adhering to what they should do, and it's due to prices, that obviously is going to lead to other things down the road that become very expensive on a health plan. So having that consumerism availability is going to be key. This is a product that you can give to your employees. You can you know, where have you ever heard this? It's a benefit you can give to them that is free to you. It doesn't cost, there's no cost to do that. It's a handout to them. And again, it just becomes a tool for them to use to shop the price of drugs against the other options they have, like their insurance on there. We know that there'll be about 5 billion prescriptions filled this year, and that's not going to slow down anytime soon. And about 80% of the time, using a benefit like CleverRx is actually going to be less expensive than an average insurance plan. And what that means to you is if we can get people taking the one and done drugs, the antibiotics, the you know, the Tamiflus and things of that nature, or the generics, the blood thinners, the statins, the heart medication, blood pressure medication, things like that. If we can get them using the technology to shop those prices out, and they can find a lower price than the insurance, it's a win-win for everybody. Now your employees are filling their prescriptions for a lower price, and nothing's hitting the insurance plan. with a company like ours, about 40% of the drugs that we cover, which is about 55,000 different medications, about 40% of those are less than $10 on our plan, which is again free to use. So there's definitely a high probability that somebody throughout the year is going to be able to use this. And if you have the average family of 4 filling 32 prescriptions on an annual basis for that entire family, getting those for less than $10 and having those go off plan and paying a cash price, that constitutes a big savings for everybody involved on there. So go ahead and go to the next slide. So the reason for the uproar, you've probably, if you've paid any attention, you've seen commercials, you've seen pay-per-click ads from similar type services that are out there that really, focus on a direct-to-consumer basis and not working in the group insurance space like what we do. But prescription drug pricing is out of control. The costs are going up and continue to go up. There's a average copay increase, as I talked about on insurance plans on there, and the number of workers moving from a PPO plan with a copay on your pharmacy is reducing. Most people are going into a high deductible health plan again with more out-of-pocket coverage, and then just lack of awareness on how this all works. If you listen to Susan's presentation, there's a lot to know, and there's a lot of people that aren't aware how this all works. They're used to just using their prescription card and going and handing it to the pharmacist and paying whatever the pharmacist tells them to pay. So there's just not a lot of awareness out there that there are options for them. Go ahead and flip to the screen. So discount prescription cards, currently there's over 10 million users of these. I think a lot of people have heard of GoodRx out there. They're certainly the leader in this industry. CleverRx is who I work for. We focus more in the employer space, where we work directly with employers to offer lots of benefits to the employer for offering this to their employees, such as reporting and real-time access to see usage on these types of drugs. We have co-branded sites for you, so you can put your company name on a site and get that to your employees, make them feel good about using something like this, whether it's on the app or on the website, to go in and look at the price of the drug and find a pharmacy within their area that has the drug for, in some cases, 80% of the time, lower than their insurance. A lot of people aren't aware that within the same zip code, drug prices can vary pretty significantly between pharmacies on there, and that's what our technology will show. Go ahead and flip one more. And so the biggest challenge is just awareness, and that's kind of where you come in. If this is a benefit that you make available to your employees, we've got, with our help, make them aware that this tool is out there. And again, it's a tool. It is not a replacement for anything. This layers right on top of whatever else it is you're doing. But if you are messaging the fact that, hey, there are other options beside your insurance, because many still, again, hold that false belief that insurance is always the best or lowest price, and that's definitely not the case. Many people don't know that the price changes from pharmacy to pharmacy, and that's what our technology will show. And it's getting better now, but it's never been really a habit to check pricing before going to the pharmacy. If you are on a drug and you're on, say, a statin, like Susan was pointing out, and that's a drug that you're going to fill a prescription on every 30 days or every 90 days or whatever it may be, generally you're going to go to the pharmacy you've always gone to and fill that prescription. But looking at that through our app, the price difference varies by almost $15 for that drug from pharmacy to pharmacy. So it might be worth using the technology, and that's kind of that education piece to shop that out. You know, members who use something like CleverRx are ahead of the game. They're going to find that a lot of the times there's a better way to purchase their drugs, and that's only going to help you, especially if you self-fund and you can keep these all off plan for sure. And then again, it's just educating you all that you know, hey, there are options out there. There's great things that we're doing with employers that are free of charge, and it's you that are going to help engage your employees to help them understand that consumerism is alive and well in the pharmacy space. So with that, I'll turn it back over to Sarah.
So Pete, a question for you, because we're going to roll into the AeroRx portion, more of the high cost drugs. With the CleverRx and some of these other, the good RXs, in those cases, we're mostly looking at non-specialty drugs, correct? This is probably ones that they can just go to the pharmacy and get. If one of the things we like to comment on for those on the call, that if you were to look at your own plan, let's say you look at your renewal, for us on the Aero side, we say, you know, take a look at your top drugs by spend list, and that's the ones we focus on. Would it be fair to say on the CleverRx side, it might be your top drugs by volume, like the frequency? Those are the type of drugs usually that might be a good fit for going through CleverRx?
Yeah, absolutely. Where we're going to shine is in that generic space for sure, that tier 1, some tier 2 drugs, but definitely when you get into the specialty drugs and things of that nature, you know, it's really, really difficult to make a case for using CleverRx in those cases. It's just not what we're designed to do. It's more into that the generics, the ongoing drugs that people are going to take on a daily basis. So the lower cost drugs, but we are getting them for even lower than the low cost a lot of times.
Yeah. All right. Perfect. Thank you so much, Pete.
Mm-hmm.
So now we're going to move into that high cost drug management space. So when we are looking at high cost drug management, at the beginning, I talked about specialty drugs, and specialty drugs definitely fall within that. But when it comes to the Aero program, we're not just looking just at specialty. We have a definition for high cost, and we're going to get into that in just a moment. And so Vince Babcock, that is a principal and benefits consultant with 44 North, developed and heads our AeroRx program. So he and I are going to go back and forth here on high cost drug management. So to start us off, I used GoodRx. I should have used CleverRx in this example, but like Pete talked about, you can go out and use that app. You can use that technology to be a better consumer and see how much these medications actually cost and where you can get them for the lowest cost. So we like to use that third-party app to talk about the cost of even the high-cost drugs. So a couple examples that we're going to use, and we're going to touch on Humira repeatedly as we talk through high-cost drug management because it's so common. Most likely, if you are a plan, you've got employees 100 or more, you probably have at least one case of someone on Humira. And Humira treats everything from rheumatoid arthritis to Crohn's,
Psoriasis.
to psoriasis. Thank you, Vince. And so if you were to go out on GoodRx or CleverRx and say, what is the cost of Humira? You would find that it costs about $5,500 per month. So if you have one person, usually they're taking this monthly, it's going to cost your plan about $66,000 per year. Again, the member, from their eyes, it's a copay, it's a deductible, but the plan is paying about $66,000 per year. So that's a more common one, Humira. Now on the right-hand side of your screen, you see Stelara. Again, nice, beautiful commercial that you've probably seen as you're watching TV at night. But Stelara is newer to market. It treats the same type of things as Humira, but the cost of Stelara, as the newer version of Humira, is $23,000 per month. If someone's taking that each month, it's going to cost the plan $273,000 per year. So not only do you have these high cost drugs, but as new drugs come out, to Susan's point, Humira doesn't, there's not a generic out there. You just have the newer version. And as people are on Humira longer, it may not be as effective as they take it longer. So we're starting to see where physicians are moving their patients from Humira over to these Stellaras. And what we're identifying really is less than 2% of claimants. So we have these high dollars, but the number of people that are on these types of drugs is less than 2%. So if we take a nice round number of 100 employees, only 1 to 2 are going to be on a drug like this. But they're going to account for anywhere from 40 to 50% of the total plan spend. And what we're trying to do by identifying those and targeting those is how can we get those for free? And our solution is called ARO-RX. The ARO stands for Alternative Reimbursement Opportunity. So when we say free to the plan, we don't mean the member can't take that drug anymore. We're not trying to do any traditional type of switching on them or step therapy for them to take a different drug. It's just an alternative way to source it and pay for that drug. And so the way that that works is your employee is going to get a prescription. And the way we define what a high cost drug is any generic that's over $400 for a 30-day supply, and any brand name drug that's over $1,000 for a 30-day supply. And if the answer is no, it's not a high cost drug, then the member goes and gets their prescription filled at the same pharmacy they always have. They pay their same co-pays. In some instances, we may even improve the benefit because of the savings on the other. And again, that's only 98%, or not only, that is 98% of the drugs, right? There's a very small amount. And so if the answer is yes for that 2%, that's where they are engaging with the ARO program, where it's a concierge service of how they receive those. And so Vince is going to walk you through more detail on how do we accomplish that.
Yeah, so to Sarah's point, this really is a concierge service they don't have now. When we engage with the employer, our goal is going to be to make it free to the employer or as low cost as possible. And we're going to use one of 3 basic strategies. And the first one is an alternative reimbursement strategy. We're able to move most people into this strategy, about 85% success rate. And what that means is that we're going to use various different reimbursement strategies, but for the most part, it's like a manufacturer's assistance program. This is manufacturer money that they set aside, and it's 0 cost to the employee, zero cost to the plan, as long as the employee qualifies by income. And it's a function of federal poverty level. The more expensive the drug, the higher the multiple. But for instance, Humira has about $170,000 threshold for a family of 4. Anybody making less than that is going to qualify for the program. That's why we're so successful on Humira. And also, if you want to break that down into a single, it's around $60,000, $65,000, $70,000. So it is income-based, but most people are going to qualify. I get the question of what happens when they don't qualify? What do we do with them? Does the plan just continue to pay full cost for the drug? And the answer is no. In most cases, we're going to have a copay card solution. This is the copay card that your employees are using to bring their $80 copay down to $5. The drug company is giving them $75 a month so that they can painlessly take Humira or whatever it is. Humira will give us $20,000 a year on that copay card. And when we use it, we bring the employee back to the plan and adjust the copay internally. It's seamless to the employee. And we use all of Humira's $20,000. If they're going to give us $20,000, we're going to use it. And it's going to be all plan savings, minus the difference in the copay for the employee down to, I think the card makes us do $5 these days. So $5 to the employee if we have to go to the second strategy for a drug like Humira. And then what we do once that copay card is exhausted is we're going to ship that drug from Canada to the employee. So it's the same drug, same manufacturer, just half the cost because Canada has price controls. And between the second box and the third box, worst case scenario for a drug like Humira is you're going to pay about 1/3 of the cost of what you're currently paying for that drug. So this is the process, and this would be like an implementation to lead up to the go live date. Normally we can identify the people that are on these drugs through a claims file, and we're going to do active outreach on the 60 to 90 days before the go live date while they continue to fill their drugs on the current plan. And we're going to do all the paperwork necessary, gather up all the data, and submit it the right way the first time, and follow up with these programs relentlessly until they give us a yes or a no. And in that manner, we're going to take care of all the people that are on a high-cost drug now on the go live date. So this creates immediate planned savings. This isn't a strategy that takes 2 or 3 years to see a return on investment. This is a strategy that doesn't shift people around from the drug that their doctor has prescribed. This is a strategy that provides immediate savings and maintains the drug that the doctor prescribed to the patient. Go ahead. So our results, 40 groups saved in 2019. We did $100,000 in savings per every 100 employees. We've looked at our book of business, and that's ringing very true. In 2019, Humira, we did $1.457 million in savings. Enbrel, that's a Humira type drug, it was $637,000. And every now and then we do get a one-off drug that's not one of these maintenance medications that you see on TV. This is an example of one of them. This is Kalydeco. This treats cystic fibrosis. This is one family, and it's $576,000 saved to the plan and free drug to the members over the course of 2019. And then these are our per fill savings for 2019. We've updated this, they're actually bigger now, but Humira in 2019, we were saving $4,779 per fill. Enbrel was at $3,889. Kalydeco is obviously a little bit bigger because the per fill is a larger number. And then on the right, we have our 2019 top 10 international program savings. Now, we don't just use international for the fallback position if somebody might make too much money to qualify for box 1 on that previous slide. After we're done taking care of all the really big drugs, we do go back to the file that we now can see every day, and we look for drugs that are good opportunities for Canada, and those are generally going to be things like diabetics, inhalers, things like that. Our diabetic people love our Canadian program because they get the drug they want at the quantity they want, and that's not always the case on stateside plans these days. So Sarah, I'll let you take this one.
Sure. So I'm going to step back because I don't think we have it on here. But I want to make a mention of this too, because we talked about it at the beginning about how with the increasing cost, you know, people think that your carrier's working on it, right? There's programs out there. I'm starting to hear, yeah, my carrier, some of this sounds familiar. My carrier seems to be coming out with programs like this. And some of the big carriers are starting to incorporate that box 2 of what Vince went through, how we have the 3 different ways that we walk through, how are we going to find the savings. So we are starting to see where carriers are getting into that space, but certainly you're limiting your ability for the maximum savings that you can get on those. So you are going to start hearing that. Just know that as you dig into it, what other options are out there, and are they really taking advantage of all the savings that are available? So one of the things that Vince talked about is how on day 1, right, you're not waiting 2 years for this to eventually show up in some kind of savings in your renewal. You're going to see savings day 1. You'll see a huge drop in cost. So here's an example. This is a case study. We had a group that has 750 employees. In 2017, their spend just on prescription claims was almost $2 million. They engaged with Arrow at the beginning of the 2018 plan year, and by the end of the year, total cost in those claims was $420,000. You can see the chart on the left bottom there where they're spending all the way from back in 2016, right? You're going to have ups and downs as you go along, but you hit that November 2018 and you can see day 1, drop in the cost of what they were paying for that plan. So some of the big names over on the right-hand side, the Tagrisso, of course, you're going to see the Humiras in there. So this plan saved 77% from the year before, $1.5 million on what had been previously a $2 million spend.
Now, 77% is a big number, and it's probably our biggest to date. But we typically, I'm not shocked when I see 55% to 60% savings.
Mm-hmm. So reasons why businesses don't do this. Number one is convenience, right? So we talked all the way at the beginning, all of these things that go into when you turn into moving to self-funded, right? You're used to the convenience of that one card, even though they show how the PBM may be a different PBM. You know, the big carriers provide the convenience of one card, but that convenience can definitely be very expensive. Conflict of interest. Carriers and even brokers aren't showing this as much because how do they make money? The higher your premiums, right? The more that they're making as well. And then the clarity. Again, if you're in a fully insured situation, you have no clarity about where your spend is and what savings can be out there. Oh, here, I jumped ahead, Vince, on the difference between Arrow and what the major carriers are. So
yeah, we don't need to spend a ton of time here, but we want to make sure that everybody understands that, you know, there are a number of different strategies out there to take care of your pharmacy benefit spend. Typically, they're going to include closing down the formulary to a smaller level, you know, or just saying, hey, we don't cover all that. They're going to do forced alternative treatment paths. That means that if your doctor prescribes one thing, they may say you can't have this, you have to take that. And we've seen that in oncology situations where a doctor prescribed a cancer drug and the PBM said you can't have that cancer drug. To me and to our team, that is not our philosophy. That seems like a bad way to go. And after it's all said and done, after all this disruption, you're going to see maybe a 12 to 20% drop in your spend over the course of a year or two. They are starting to use copay cards internally, so they're doing that box too, but they're spreading them out over the course of a year. What happens if the employee doesn't stay with you for a year? You didn't save the entire potential of $20,000 in Humira's case. And then they don't have an international solution. So once the copay card is exhausted or they spread out over the year, that's the most you're ever going to get. They do tout rebates. We're rebate eligible as well. I like to say that if you're chasing rebates, that is part of the current system. Right now, you get a rebate based on every time your employee fills a drug. It's their gift to you at maybe 15 to 20% of the cost of the drug. It seems like a pretty poor gift to me. So I would like everybody to consider getting on the other side of that equation and getting their employees the drugs and realizing the lion's share of the savings.
All right, thanks, Vince. I am going to open it up for questions. If you want to type your questions in the question and answer section, I'm going to go ahead and wait for any of those to come in. But at the same time, just for the interest of our last 4 minutes here, as you type in those questions, I'm going to go through just some housekeeping next steps. So with the PinPoint plans and with the strategies that we're talking about, one of the things that we can do is an impact analysis. And if you've been on previous presentations, you've seen, we always end with this. We would love to be able to show you what can we do with your plan. Obviously, there's no commitment to move forward with it, but let us take a look. Let us show you maybe what these strategies can do to impact your plan. Let us help you. Let's continue the conversation through our next couple episodes. So we're right in the middle of our webinar series focused on prescriptions today, but the next ones coming up is going to, in October, is going to be based on value-based pricing. And that's a really unique new concept, maybe not completely new. You've probably heard of things like reference-based pricing, but the way that PinPoint addresses it and does it is unique. And I think it'd be really valuable to at least hear that portion too. So in October, be looking for the invite for that episode. And then our final webinar will be on alternative reimbursement. So be on the lookout for those. Definitely sign up as those come along. And so October 13th will be the value-based plan designs. The easiest way to save 20% on your healthcare spend. So today we're talking about prescriptions. We're going to be focusing on the medical plan on the next one. So again, watch for those emails to register. If you want to have an impact analysis, you can send your quote request to pinpoint@breckpoint.com. Of course, your advisor that invited you to today's webcast, you can reach out to them. Certainly, if you email us directly, we'll certainly loop in your advisor as well. But you could easily email us at pinpoint@breckpoint.com. So I want to thank you all. We don't have any questions that have come in. Do we have one? Okay.
Yeah, we got one on the group chat. It's for Pete.
See that.
Pete, you still there?
I am here, yep.
Do you see the group chat? It says, can CleverRx be used at Kaiser facilities?
Yeah, I see it now. So we are available in about 76,000 pharmacies across the United States. I don't have any Kaiser facilities in my area, so I'm not sure. I'd have to get back to you on that. What I can tell you is where we really shine is, again, we're taking at 76,000 plus pharmacies, but the top four, the Walmart, the Walgreens, the CVS, and Kroger grocery stores, we have direct relationships with. And generally that's going to be our best pricing. And so the best way to find out on which facilities locally to you is to get a hold of someone through PinPoint and get CleverRx downloaded on your phone, and then take a look at your individual area, because it really does vary by the zip code.
Okay, thanks, Pete. All right, well, it's 4 o'clock. We'll leave the chat open for a couple minutes here just to take care of any questions. But thank you again for attending today, and be on the lookout for those, the recording. We'll send out an email that has a link to that recording, as well as future invites. Thank you, everybody.
Thank you.
Thank you.